Welcome back to the Deep Dive. Today, we are stripping things back. We're decluttering the desk. Usually, we have this messy stack of papers. We're cross-referencing 3 or 4 different textbooks, comparing guidelines, trying to find that middle ground. But today is a solo expedition.
It is. We are going single source today because we're tackling a subject that, well, it demands a specific kind of rigor.
Right.
We are diving exclusively into Goodman and Gilman's The Pharmacological Basis of Therapeutics, specifically the chapter on ocular pharmacology.
Now, we should mention right off the bat for our regular listeners who like to follow along or use these dives as a revision scaffold, there is no Katsung match for this one.
No, and that's significant. Katsung is fantastic for the broad strokes, the clinical organization, the what do I prescribe first logic.
Yeah, scaffolding.
It's scaffolding. But when you get into the eye is different. It's a completely unique pharmacological environment.
A universe unto itself.
Exactly. To really get the molecular reasoning, the physics of delivery, the systems level logic of why we treat the eye the way we do, Goodman and Gilman is the gold standard here. It gives us that mechanistic depth we need.
It's really the only text that treats the eye as its own distinct pharmacological universe.
Yeah.
And universe is a good way to put it because when you read this chapter, you get this profound sense of isolation. The title for today's dive is Precision at the Edge of Perception. And I think that captures the tension here perfectly. The eye feels like a fortress.
It is a biological fortress. That is the single defining characteristic of ocular pharmacology. You're dealing with this tiny, incredibly delicate sphere millimeters of tissue that is chemically and physically walled off from the rest of the body.
Right.
It's protected by bone, by lids, by tears, and by these microscopic barriers that are just incredibly hard to breach.
And that isolation, that creates the central dilemma we're going to be wrestling with for the next hour, right?
It's the whole game.
The central tension is this. How do you treat a fortress? How do you get a drug inside without destroying the walls?
And conversely, how do you keep that drug from leaking out and, poisoning the rest of the kingdom?
That's the Goldilocks problem of eye care, isn't it?
It really is. The eye is a specialized sensory organ. It has the blood-retinal barrier and the blood-aqueous barrier. And these aren't just metaphors. They are, actual tight junctions between cells that prevent systemic blood from mixing with the fluids inside the eye.
So if you swallow a pill, say an antibiotic,
almost none of it gets to the eye. It's just kept out. But, and this is the paradox, if you put a drop in the eye, as we'll see, it has a surprisingly direct route to your heart.
hard to get in, easy to leak out. It's a total paradox.
That's it, in a nutshell.
So give us the roadmap. As we lay siege to this fortress today, what are the key takeaways we're hunting for?
Okay. First, we have to start with the walls. Section 1 is all about anatomy and barriers. We need to understand the cornea, why it's chemically designed to repel almost everything.
The fat-water-fat sandwich.
That's the one. Then, once we figure out how to breach the wall, we have to deal with the plumbing inside.
Glaucoma, the plumbing problem.
Exactly. Glaucoma is a plumbing failure. It's a pressure problem in a closed system. So we'll look at how we manipulate the faucet production and the drain outflow.
Okay.
Then we'll move on to invasion infection and inflammation, the red eye. The contact lens nightmares, the things that bring people into the ER.
And we're going to spend some time on the posterior segment, right? The back of the eye.
Yeah.
Because that's where the biggest pharmacological revolution has happened in the last couple of decades.
Oh, absolutely. The anti-VEGF era. It completely changed the game for macular degeneration.
And then to finish.
We're going to flip the script. We usually talk about drugs for the eye. We're going to end by talking about systemic drugs, things you take for your heart, for malaria, for your prostate, that accidentally attack the eye.
Pharmacology in reverse. I like it. And the biochemistry of sight itself.
We have to. Vitamin A, the molecule that literally makes vision possible. It's a beautiful bit of biochemistry to finish on.
All right. Let's stand at the gate. Section 1. The fortress. Anatomy, barriers, and delivery. The first thing that really struck me in this chapter is that the eye is not a passive recipient. It is actively, aggressively fighting against us.
It has to. I mean, think about it from an evolutionary perspective. The eye is a mucous membrane sitting open to the world.
Exposed.
It's wet, it's warm, it's exposed, it should be infected constantly, it should be dried out by the wind. The only reason it isn't is that it has this incredibly aggressive defense system.
Which starts with the tear film. Now, before reading this, I have to admit I just thought tears were Salt water, just saline.
Most people do. But if tears were just salt water, your eyes would dry out in seconds. Gravity would pull the water down, evaporation would take the rest.
So it's more complex.
The tear film is actually a complex trilaminar barrier.
Trilaminar, 3 layers.
3 distinct layers, each with a very specific chemical function.
Okay, walk us through the chemistry here, because this really explains why eye drops are so inefficient.
Let's look at the layers from the outside in. The very outer layer is lipid.
Fat.
It's an oil produced by the meibomian glands, these tiny little glands lining the edge of your eyelids. This oil slick sits on top of the water layer.
And its job is just physics.
Purely physics. It prevents evaporation. It increases the surface tension. If you don't have enough of this oil layer, the water just evaporates rapidly, and you get evaporative dry eye.
So it's like putting a lid on a pot of boiling water. It keeps the steam in.
Precisely. Then the middle layer, the thickest layer, is the aqueous. That's the water, the salts, the proteins, the immunoglobulins, all the good stuff that's produced by the lacrimal gland.
Okay.
And then the bottom layer, the one touching the cornea itself, is mucin. Mucus.
Oh, hi, mucus. That sounds, well, counterintuitive.
It's absolutely essential, and it's because of the cornea's chemistry. The surface of the cornea is hydrophobic. It hates water.
Really?
Yes. If you just poured water on the naked cornea, it would beat up like rain on a freshly waxed car. You wouldn't get a smooth optical surface.
I see.
The mucin acts as a surfactant. It's a wetting agent. It lowers the surface tension and allows that aqueous, watery layer to spread evenly across the surface of the eye.
So you have this oil-water-mucus sandwich constantly washing over the eye. And from a pharmacology standpoint, this is our first enemy.
It is the washout effect. The moment you add a drug, the eye reacts.
How so?
You put a drop in the eye, let's say 50 microliters, which is a standard drop size. The eye instantly recognizes a foreign volume.
Because it's too much.
Way too much. The normal tear volume is only about 7 to 10 microliters. So you are flooding the eye with 5, 6, 7 times its normal capacity.
So most of it just overflows immediately.
It overflows onto the cheek, which is useless. But the eye also triggers a reflex blink and a flood of fresh tears to flush out what it perceives as an irritant.
So the drug is just gone.
Within minutes, the vast majority of that drug is literally washed down the drain. This is why the bioavailability of eye drops is so low, often, as you said, less than 5%.
And this is where the story gets a little scary. The drain. The nasolacrimal duct. This is the mechanism that really blew my mind regarding safety.
This systemic trap. This is one of those anatomical quirks that completely changes how we have to think about drug safety.
Okay, so let's trace the path. We put the drop in, the tears and the drug mixed with them drain out of those little holes in the corners of your eyelids.
Your puncta?
The puncta. They go into a sac and then down a tube into the nose.
Correct. The nasolacrimal duct dumps right into the nasal cavity. Now, think about the lining of your nose. It is highly, highly vascular.
Right, it's designed to absorb things. That's why nasal sprays work so well.
Exactly. It's a mucous membrane designed to warm air and absorb particles, which means any drug in those tears gets absorbed directly into the bloodstream through that nasal mucosa.
And this is the critical part, isn't it?
Yeah.
It enters the bloodstream after the liver. It completely avoids first-pass metabolism.
That is the whole story right there.
Break that down for us. Why does first pass matter so much? We hear that term in pharmacology all the time.
When you swallow a pill, let's say a beta blocker for your heart, it goes into your stomach, gets absorbed by the gut, and the very first place it goes is through the portal vein, straight to the liver.
The body's detox center.
The detox center,
Uh-huh.
the chemical processing plant. The liver breaks down a huge percentage of that drug before it ever reaches your heart or your lungs or your brain. It's a massive safety buffer.
So if it goes through the nose,
It skips the filter. It goes directly into the venous return to the heart. So a tiny drop of a powerful beta blocker like timolol applied to the eye.
yeah.
It can hit the heart with the potency of an IV injection. The overall concentration in the blood might be low, but that initial bolus hitting the sinoatrial node is significant.
That is wild. So you're trying to treat glaucoma, a local eye problem, and suddenly the patient collapses from bradycardia,
Yeah.
a slowed or even stopped heart.
It happens. Or a severe asthma attack. We'll talk more about timolol later, but it blocks beta-2 receptors in the lungs too.
Right.
If an asthmatic patient absorbs enough timolol through their nose, their airways can constrict rapidly. We have had patients ending up in the ER with acute respiratory distress, and the cause was their eye drops.
Just from an eye drop, that really redefines the concept of a local drug.
It does, and this is why adherence and, just as importantly, technique are pharmacological variables. We have to teach patients punctal occlusion.
which is just a fancy way of saying.
Plug the drain. You put the drop in and you physically press your finger against the inner corner of your eye right over the punctum.
For how long?
Hold it for a minute or two. This does two things. It keeps the drug in the eye where you want it, and it keeps it out of the nose where you don't.
Such a low-tech solution to such a high-tech problem.
It is, but it can effectively double the ocular concentration of the drug and cut the systemic toxicity in half. It is probably the single most important thing we can teach a patient using drops. It turns a sloppy dose into a precise one.
Okay, so let's say we've done that. We've managed to keep the drop in the eye. Now it has to get through the cornea. You mentioned earlier the cornea is hydrophobic, but the chapter describes it as a fat-water-fat sandwich. That just sounds like a nightmare for a drug developer.
It is the second great barrier. The cornea is the clear window at the front of the eye, right? To get into the anterior chamber where it can do its work, a drug has to pass through it. But the cornea has these layers with very, very different chemical preferences.
So let's strip the layers back. Layer 1, the outside, the epithelium.
This is the outer surface. It's about 5 to 7 cell layers thick, and the key thing is the cells have tight junctions.
Meaning nothing slips between them.
You have to go through them. And the cell membranes are lipid-rich. So the epithelium is lipophilic, it loves fat, it resists water.
So if you have a purely hydrophilic drug, one that loves water, it just bounces off.
Effectively, yes. It can't penetrate that lipid membrane. It's like trying to push water through oil. It's not going to happen.
Okay, so layer 2, the stroma.
This is the thick middle layer. It makes up about 90% of the corneal thickness. It's made of these beautifully organized collagen fibrils in a very specific lattice to be transparent.
And it's wet.
It's hydrated with water. It is hydrophilic. It loves water. It resists fat.
And then layer 3, the inside, the endothelium.
A single monolayer of cells on the back surface.
Okay.
It's lipophilic again. Loves fat.
So imagine you are a drug molecule. To get into the eye, you have to be able to dissolve in fat to get through the first door. Then you have to dissolve in water to get through the long hallway. Then you have to dissolve in fat again to get out the back door.
That is a perfect visualization, and it creates this massive constraint on chemical engineering. To be an effective topical eye drug, a molecule must be amphipathic.
Amphipathic.
Amphiphyte meaning both. It has to have this split personality. It needs a lipophilic part to cross the epithelium and endothelium, and it needs a hydrophilic part to diffuse through the stroma.
And if it's too much of one or the other,
it gets stuck. If it's too lipophilic, it crosses the epithelium, and then it just sits there in the stroma, forming a depot. It can't get out. If it's too hydrophilic, it never even gets in.
This explains why we have so many different formulations. You know, solutions, gels, ointments. It's not just about patient preference, it's physics.
It's a trade-off between contact time and vision. An ointment, which is basically petrolatum, like Vaseline, is great for lipophilic drugs. It sits on the eye, it doesn't wash away, and it allows the drug to slowly partition into those lipid layers. But have you ever put ointment in your eye?
Oh, yeah. It's like looking through frosted glass. Your vision is just completely blurry.
Exactly, can't see. So we can really only prescribe ointments for patients to use at bedtime. For daytime, we need drops or gels that clear quickly.
And for the really hard-to-reach places. Or for drugs that just can't penetrate that sandwich at all, like big protein molecules.
Then we have to bypass the barrier entirely. We have to inject. We can do subconjunctival injections, which is just under the clear skin of the eye. We have retrobulbar injections, where we navigate a needle past the eyeball into the muscle cone behind it, usually to numb the nerves for surgery.
And the big one, intravitreal.
Putting a needle directly through the wall of the eye into the vitreous jelly in the back, it bypasses the cornea, the iris, the lens, everything. It puts the drug right where it needs to be, right next to the retina.
We are definitely going to get to that when we talk about the retina, because that sounds horrific, but apparently it's completely routine now.
It's the most common intraocular procedure performed in the world today. But before we get to the back of the eye, let's talk about the most common disease we treat with those topical drops.
Section 2, the plumbing problem. Glaucoma.
Glaucoma is the bread and butter of ocular pharmacology. And it's just fascinating because it is, at its core, a physics problem that we solve with chemistry.
Okay, let's define the enemy first. What is glaucoma? I think most people just hear high pressure. My grandma has high pressure in her eye, so she has glaucoma.
And that's the risk factor. But it's not the disease itself. Glaucoma is a specific type of brain damage.
Brain damage.
It is a progressive optic neuropathy. The optic nerve, which connects the eye to the brain, is made up of over 1 million individual nerve fibers. In glaucoma, those fibers die. Specifically, The retinal ganglion cells undergo apoptosis-programmed cell death.
And this leads to a very specific look that an eye doctor can see.
It does. We call it cupping. Imagine the optic nerve head is like a donut. The rim of the donut is the healthy nerve tissue. The hole in the middle is the cup. As those nerve fibers die away, the rim gets thinner and the hole gets bigger. The cup expands.
And the main culprit driving this is pressure.
Intraocular pressure, or IOP. Oh, it's complex. You can have very high pressure and no damage. That's just ocular hypertension.
Okay.
Or you can have statistically normal pressure and still be going blind from glaucoma. We call that normal tension glaucoma.
But regardless of the starting pressure, the treatment is always the same.
For now, yes. Currently, lowering the IOP is the only proven way to stop or slow the progression. Even in normal tension glaucoma, we have to get the pressure lower than normal to take the stress off that nerve.
Okay, so let's get into the plumbing. How does the fluid, the aqueous humor, move? Because if we want to lower pressure, we have to understand the flow.
It's a dynamic system. Think of a bathtub with the faucet running and the drain open. The water level in the tub is the pressure.
Right.
The faucet is the ciliary body. It's a structure that sits behind the iris, and it actively produces this fluid. It pumps ions, and water follows by osmosis.
And the fluid flows from behind the iris through the pupil.
Into the front of the eye, the anterior chamber.
No.
And then it has to leave. If you keep the faucet running and you plug the drain, the pressure spikes.
And there are two drains.
Two exits, yes. The first one's the conventional pathway. This is the trabecular meshwork. Think of it like a mesh sieve or a tiny sponge that sits in the angle where the iris meets the cornea. The fluid filters through this mesh and drains into a little channel called Schlemm's canal and then into the venous system.
And that's the main one.
It is. It handles about 80 to 95% of the outflow.
Okay, and drain number 2. This is the one that a lot of the newer drugs target.
This is the uveoscleral pathway. This is less of a pipe and more like seepage. There isn't a discrete hole. The fluid just sort of oozes out between the muscle bundles of the ciliary muscle and into the suprachoroidal space.
Like water seeping into the ground rather than going down a storm drain.
That's a great analogy. So we have the faucet, the ciliary body, and two drains, the trabecular meshwork and uveoscleral seepage. All the glaucoma drugs basically target one of these 3 points.
Let's start with the new kings of glaucoma therapy, the prostaglandin analogs.
Drugs like latanoprust, travoprust, bimatoprust. If you know someone with glaucoma, odds are they are on one of these. They really revolutionize treatment because they're once a day and they're incredibly effective.
So how do they work? Which part of the plumbing do they hit?
They target that secondary drain, the uveoscleral outflow. They act on FP receptors, which are prostaglandin M receptors.
Oh.
But here is the really cool part.
Oh.
They don't just, open a valve. They chemically remodel the tissue itself.
Remodel. What does that mean?
It means they trigger the release of enzymes called metalloproteinases. These enzymes actually start to digest the extracellular matrix, the grout, between the muscle cells of the ciliary body.
So they're dissolving the resistance.
They are literally dissolving the resistance, making the tissue more permeable so the fluid can seep out faster. It's not mechanical, it's structural remodeling.
That is incredibly sophisticated.
It is. And latanoprust itself is a great example of a prodrug, which goes right back to our barrier discussion. It's formulated as an ester. Why? Because the ester form is more lipophilic. It helps the drug penetrate the corneal epithelium.
The first fatty layer.
Exactly. Once it's inside the cornea, enzymes called esterases clip off that tail, activating the drug into its acid form so it can work on the receptors.
Now, the side effects of these are, they're famous.
They are unique. The most famous one, of course, is hypertrichosis. Your eyelashes grow long, thick, and dark.
Which is why bimatoprust was repackaged and sold as Latisse for cosmetic use.
Exactly. A glaucoma side effect became a billion-dollar beauty product. But there are other effects. They can cause periorbital fat atrophy. The fat pad around the eye actually shrinks, giving you a sunken, hollow look. We call it prostaglandin-associated periorbitopathy, or PP.
And the most permanent one, the change in eye color.
This is the one that scares people. If you have hazel or green or blue eyes, any kind of mixed pigment, these drugs stimulate melanogenesis. They make the pigment cells in your iris produce more melanin.
And your eyes can turn brown.
They can turn a uniform chocolate brown. And it doesn't revert when you stop the drug. The melanin granules are there to stay.
So you save your vision, but you literally change your face.
It's a conversation we have to have with every single patient. Now let's look at the faucet drugs, the production suppressors.
The beta blockers.
Timolol.
Before prostaglandins came along, These were the gold standard. They work on the ciliary body epithelium. The cells that make the fluid have beta receptors on them, mostly beta 2.
Mm-hmm.
When you block those receptors, you decrease the intracellular levels of cyclic AMP, which downregulates the active transport of fluid. You are, quite literally, turning down the tap.
But this brings us right back to the systemic risk we talked about. Timolol is non-selective.
That's the problem. It blocks beta 1 in the heart and beta 2 in the lungs. We already mentioned the risk of bradycardia and bronchospasm in asthmatics. There is a selective version betaxolol that only blocks beta 1, so it's much safer for the lungs.
But is it as effective at lowering pressure? Unfortunately, no. Because the ciliary body primarily has beta 2 receptors, blocking only beta 1 doesn't turn the faucet down nearly as much. So Betaxol is safer, but it's weaker. It's always a trade-off.
What about the alpha agonists, like brimonidine?
Brimonidine is interesting because it's a dual agent. It hits two parts of the plumbing.
Oh.
It decreases production, and it increases uveoscleral outflow. It's an alpha-2 adrenergic agonist.
That sounds perfect. Why isn't it the first choice for everyone?
Toxicity and tolerance. A lot of patients, over time, develop a severe allergic reaction to it, a follicular conjunctivitis. Their eyes get incredibly red and itchy. But the big red flag is pediatric use.
Why is that?
Brimonidine is highly lipophilic. It crosses the blood-brain barrier very easily. In an adult, this might cause a little bit of drowsiness or dry mouth, but in a small child whose blood-brain barrier isn't fully developed and whose volume of distribution is so small,
What happens?
it can cause severe central nervous system depression.
So it's contraindicated in kids under 2.
Strictly?
Yeah.
Absolutely contraindicated. You put a drop of this in a baby's eye and they can go into a coma. Hypotension, bradycardia, apnea. It's terrifying. It acts centrally, just like the blood pressure drug clonidine.
Wow. Okay. Let's touch on one more class in this section. The carbonic anhydrase inhibitors, or CAIs. Dorzolamide, brinzolamide.
These target the actual chemistry of fluid production. To make aqueous humour, the eye needs to transport bicarbonate ions. And to make bicarbonate, you need an enzyme called carbonic anhydrase.
So if you inhibit the enzyme,
You stop the bicarbonate production, you stop the water flow. It's simple, elegant chemistry. But the problem is that carbonic anhydrase is used everywhere in the body. It's in your kidneys, your red blood cells, your taste buds.
your taste buds.
Yes. One of the classic complaints with CAI drops is a metallic, bitter taste in the mouth. And it's not because the drop dripped down their throat onto their tongue, no. It's because the drug absorbs systemically into the blood and is then secreted in the saliva. It literally changes the chemistry of how you perceive taste.
That really just drives home the systemic nature of all this.
And if we give the oral version acetazolamide, it's even worse. It's a powerful diuretic. It causes a metabolic acidosis. It causes numbness and tingling in the fingers and toes, kidney stones. We only use the pills for emergencies because patients just feel miserable on them.
Okay, we've stabilized the pressure, but now the fortress is under attack. Section 3, infection and inflammation.
The red eye. This is probably the most common emergency presentation in ophthalmology. And the stakes are high because, as we mentioned earlier, the cornea is avascular.
Meaning no blood vessels.
Right. No blood means no direct delivery of white blood cells to fight an infection. The cornea has to rely on the tears and the limbus, which is the edge where it meets the white part of the eye, for its defense. So if a bacteria gets a foothold in the center of the cornea, a corneal ulcer, it can replicate almost unchecked.
And it can melt the eye. I read that in the chapter.
Literally. Some bacteria, like Pseudomonas aeruginosa, secrete proteases and collagenoses that just liquefy the corneal tissue. You can go from a small scratch to a perforation, a full-thickness hole in the eye, in 24 to 48 hours.
So when we treat this, we don't mess around.
No, we use loading doses. We might tell a patient to put antibiotic drops in every 15 minutes for the first 6 hours, then every hour, around the clock.
Wow.
We have to overwhelm that washout effect and keep the concentration of the drug above the MIC, the minimum inhibitory concentration for that bug.
And we use the big guns, fluoroquinolones like moxifloxacin.
Broad spectrum, potent, and they have good penetration through the stroma, but there is a scenario where all the best antibiotics in the world don't work. The contact lens nightmare.
Acanthamoeba. I read this section and I seriously wanted to throw my contact lenses away.
This is a story every single contact lens wearer needs to hear. Acanthamoeba is a free-living protozoan. It lives in tap water, well water, hot tubs, lakes, soil.
It loves contact lenses.
It adheres to the lens surface. If you swim in your contacts or shower in them or and this is a huge one-use tap water to rinse your case, you are basically inviting this parasite onto your eye.
And once it's there.
Once it infects the cornea, it is incredibly, incredibly difficult to kill. It can form a cyst stage that's like a biological bunker. It ignores antibiotics. It ignores the immune system. It just sits there.
So how do we kill it? The chapter mentions pool cleaner.
Essentially, yes, we use cationic antiseptics. The main one is polyhexamethylene big one-eyed, or PHMB. We also use chlorhexidine. These are the same chemicals used to sanitize swimming pools and surgical instruments.
You're dropping pool sanitizer into a person's eye.
We have to. It's the only thing that works. It disrupts the membrane of the amoeba. But because those cysts are so resistant, the treatment takes months.
Months.
6 months, sometimes a year of these toxic drops. Every hour. It's painful. It's toxic to the eye surface itself, but the alternative is a corneal transplant or, in some cases, losing the eye.
That is a public service announcement if I've ever heard one. Do not swim or shower in your contact lenses.
Never. The risk is small, but the consequence is absolutely catastrophic.
Okay, let's move to viruses. Hoki simplex, the cold sore virus. It can get in the eye.
Oh, yes. HSV keratitis.
Yeah.
And this is where pharmacology gets really tricky because there is a huge trap. If a patient comes into an urgent care clinic with a red eye, a well-meaning doctor might be tempted to give them a steroid drop to calm it down.
Why is that a trap?
If it is HSV epithelial disease, where the virus is actively replicating on the surface, creating these little branching tree-like ulcers we call dendrites, giving steroids is like pouring gasoline on a fire.
Why? What do the steroids do?
Steroids are powerful immunosuppressants. They turn off the local immune response, so the virus is actively eating the cells. The immune system is trying to kill the virus. If you turn off the police, the immune system, the rioters, the virus, burn the city down, the ulcer will expand rapidly and form a massive geographic ulcer. It can lead to a perforation.
So the absolute rule is never use steroids on an undiagnosed red eye.
Never. Unless you are an ophthalmologist and you have looked at that eye under a slit lamp with fluorescein dye to confirm there are no dendrites, you stay away from steroids.
But we do use steroids in ophthalmology. A lot, actually.
But I know constantly. Corticosteroids like prednisolone and dexamethasone are the most powerful anti-inflammatories we have. We use them after surgery for uveitis, which is internal inflammation, and even for some types of herpes, like the stromal type, where it's an immune reaction deep in the tissue. But we always do it with antiviral cover.
But they have a deal with the devil quality.
They do. There's a price to pay.
What's the price?
2 major long-term side effects. First, cataracts. Almost everyone on long-term steroids, whether it's drops or pills, will develop a specific type of cataract called a posterior subcapsular cataract. It's right in the center of vision, and it interferes with reading significantly.
And the second?
Glaucoma, the famous steroid response. About a third of the general population has a genetic susceptibility where steroids cause the trabecular meshwork to get gummed up.
The drain gets clogged.
The drain gets clogged. The cells in the meshwork get bloated, they deposit more extracellular matrix, and the outflow resistance goes way up. The pressure can spike into the 40s or 50s.
So what do you do if you have a patient who needs inflammation control, but they're a known steroid responder?
We have engineered solutions now. We have what are called soft steroids, like loprednol.
Soft steroids.
The molecule is designed with a metabolic switch. It's active when it hits the receptor, but it's very rapidly broken down by esterases in the tissue into an inactive metabolite, so it sort of hits and runs. It reduces the chance of pressure spikes because it doesn't linger in the trabecular meshwork long enough to cause problems.
Or you can just switch drug classes entirely and use NSAIDs.
Exactly. Non-steroidal anti-inflammatory drugs. Ketorolac, diclofenac. It's just like taking ibuprofen for a sore knee, but in a dropped form. They block the cyclooxygenase, or COX, enzymes. They're great for pain after surgery and for preventing retinal swelling, what we call cystoid macular edema. And they do it all without the risk of raising pressure or causing cataracts.
Okay, let's go deeper into the fortress. Section 4. The posterior segment. The retina.
This is, for me, the most exciting part of the chapter. If we were having this conversation 20 years ago, we would have almost nothing to say about wet macular degeneration. It was essentially a death sentence for central vision. You just watch people go blind.
What changed?
The discovery of VEGF, vascular endothelial growth factor.
Explain the mechanism of wet AMD for us. What's going on?
So, in age-related macular degeneration, the retina, particularly the macula, starts to struggle. It becomes ischemic. It's starved for oxygen.
Oh.
In a state of panic, it starts screaming for help by releasing a signal protein called VEGF.
And that signal tells the body.
Grow more blood vessels. We need more oxygen down here.
That sounds logical. The body is trying to heal itself. Why is that a bad thing?
Because the body does a rush job. These new vessels, we call it neovascularization, are incompetent, they're fragile, they lack proper tight junctions, they are leaky. They leak fluid, they leak blood, they leak protein, all under the macula.
Like a pipe bursting into the floorboards of your house.
That's the perfect analogy. And that fluid destroys the delicate architecture of the photoreceptors and eventually leads to a scar. You lose your central vision. You can't read, you can't drive, you can't recognize faces.
So the solution is to block that signal, to block the VEGF.
Exactly. We inject an antibody, or a piece of an antibody, that acts like a molecular sponge. It just floats around in the vitreous and binds up all the free VEGF molecules. The signal stops, the vessels stop growing, the leaking dries up.
And the delivery method is that intravitreal injection we teased earlier.
Yes. We numb the eye with drops or gel. We use an eyelid speculum to keep it open. And we insert a very, very fine needle, a 30 or 32 gauge needle, through the pars plana.
Why the pars plana specifically?
It's a small zone about 3.5 to 4 millimeters behind the colored part of the eye, the limbus. And there's nothing important there. There's no retina, there's no lens, there are no major blood vessels. It's the safe zone to enter the vitreous cavity without causing damage.
And the drugs involved.
Yeah.
There's a fascinating economic and ethical story here. Bevacizumab versus ranibizumab.
Oh, this is a classic case study in pharmacology and health economics. Bevacizumab, brand name Avastin, is a full-sized antibody. It was developed and FDA approved for metastatic colon cancer.
For cancer.
For cancer. It cuts off the blood supply to tumors. It is produced in massive quantities, so it's relatively cheap per milligram.
And ranibizumab.
Brand name Lucentis. It was developed by the same parent company, Genentech, specifically for the eye. They took the bevacizumab molecule and they basically chopped off the tail, the FDC region, leaving just the antigen-binding fragment, or Fab.
And the theory was?
The theory was that this smaller molecule would penetrate the retinal tissue better. It is approved specifically for the eye, and it is priced, well, aggressively.
How big is the price gap we're talking about?
We're talking about, at the time, roughly $50 per dose for compounded Avastin versus maybe $2,000 per dose for Lucentis.
Wow. And does the expensive one work better?
That's the billion-dollar question. Large government-funded trials, like the famous CP trial, compared them head-to-head, and they found essentially no difference in visual outcomes for most patients.
So ophthalmologists all over the world just use the cancer drug off-label.
Millions and millions of injections a year. It basically keeps the healthcare system from collapsing under the cost of treating this epidemic of macular degeneration. It's a real triumph of clinical pragmatism.
Before we leave the retina, I want to touch on what you call the systemic reverse, Section 5. Usually we worry about eye drugs affecting the body. What about body drugs affecting the eye?
The eye is the ultimate canary in the coal mine. Because the cornea and lens are transparent and because we can look right through the pupil and see the retina, we can see things accumulating there that we could never see in the liver or the heart.
Okay, give us the highlights. The greatest hits. Amiodarone.
The heart rhythm drug. It causes cornea verticillata. The drug itself is amphiphilic, and it binds to polar lipids inside the lysosomes of cells. It accumulates in the corneal epithelium and creates these beautiful golden brown whorl patterns. They look like a vortex or like cat whiskers on the eye.
Does it affect vision?
Usually not. It's almost always asymptomatic, but it tells the doctor that the patient is heavily loaded with the drug. It's a biological marker of systemic burden.
What about the malaria drugs? Plaquenil or hydroxychloroquine?
Now, this is much more serious. Plaquenil is used all the time for lupus and rheumatoid arthritis, and it has a very high affinity for melanin.
And where is there a lot of melanin in the eye?
The retinal pigment epithelium, the RPE, in the back of the eye. The drug concentrates there and eventually becomes toxic to the overlying photoreceptors.
And the pattern it causes is iconic in ophthalmology.
Bullseye maculopathy. You get this ring of damage around the very center of vision. It looks exactly like a target. And the terrifying part is, if you see this, it's too late. The vision loss is permanent, and it can progress for years even after the patient stops the drug.
Why?
Because the drug stays bound to that melanin for months or years. It's a slow-release poison. That's why anyone on Plaquenil needs a visual field test and an OCT scan every single year.
What about the blue pill, Viagra or sildenafil?
This is a great example of enzyme crosstalk. Sildenafil works by inhibiting an enzyme called PDE5, phosphodiesterase 5. This prevents the breakdown of cGMP, which keeps blood vessels dilated for an erection.
Right.
But the retina uses a very similar cousin enzyme, PDE6, for phototransduction, for processing light.
And the drug isn't perfectly selective.
It's mostly selective, but at high doses, it can mildly inhibit PDE6 as well. And this disrupts the retinal signal. Patients report a blue haze over their vision, or synopsia, or just increased sensitivity to light. It wears off as the drug clears, but it's a great reminder that enzymes come in families, and drugs are rarely perfect snipers.
And finally, Flomax or tamsulosin, the prostate drug. This one sounds like a nightmare for surgeons.
It is intraoperative floppy iris syndrome, or IFIS. Tamsulosin is an alpha-1A receptor blocker. It relaxes the smooth muscle in the prostate to help men urinate more easily, but the iris dilator muscle also relies on alpha-1 receptors to contract and pull the pupil open.
So the iris just relaxes too much.
It creates a semi-permanent atrophy of that muscle. It becomes floppy, like a billowing sail in the wind. During cataract surgery, when we need the pupil to stay wide open, the iris in these patients constricts, it undulates, it tries to prolapse out of the incision. It complicates the surgery massively.
And stopping the drug beforehand doesn't help.
Not really. The change to the muscle seems to be lasting, if not permanent. If you have ever taken Flomax, even once, years ago, you must tell your cataract surgeon. They need to know so they can use special hooks or rings to mechanically hold the pupil open.
Okay, final section. We've made it. Section 6, the chemistry of sight. We've talked about fixing the eye, but how does it actually work? Goodman and Gilman ends with vitamin A.
The visual cycle. It's one of the most elegant, beautiful biochemical pathways in the entire body. And it all starts with vitamin A, or retinol.
We're all told as kids to eat carrots for our eyes.
Right, because carrots have beta-carotene, which the body can cleave into vitamin A. The eye takes that vitamin A and it converts it into a very specific, very unstable molecule called 11-cis-retinol.
Why is it unstable?
It's an isomer. Imagine a straight chain of carbon atoms. At the 11th carbon, there is a kink. The molecule is bent. It's like a loaded spring. And this molecule sits inside a protein called opsin. Together, they form rhodopsin.
The visual pigment. The visual pigment. So you are sitting in the dark. You have millions of these loaded springs in your retina ready to go. Then a single photon of light enters the eye and hits one of these 11-cis-retinol molecules.
Snap.
Instantaneously, we're talking femtoseconds, it absorbs the energy of that photon and it straightens out. It flips to become all transretinal. And this shape change, this physical movement, pushes against the opsin protein, which changes its shape.
And that mechanical shift is what triggers the whole signal cascade.
That's the beginning of vision. It activates a G protein called transducin. Transducin activates PDE6, there's that enzyme again. PDE6 lowers the level of cGMP, which closes ion channels, which hyperpolarizes the cell.
And that electrical silence is interpreted by the brain as light.
It's absolutely incredible, but it means that every single time you see light, you are using up your 11-cis-retinol. You have to recycle it. The eye has to take that spent all-trans version, ship it out to the RPE cells, rebend it back into 11-cis, and ship it back to the photoreceptor.
And if you're deficient in vitamin A, the recycling plant shuts down, you run out of pigment, and the first system to go is the rod system, which is the most sensitive to light. You get nyctalopia night blindness. You can see perfectly fine in the day, but you are functionally blind in dim light.
And if the deficiency continues?
It gets physical. Vitamin A is also needed for the gene expression that maintains the health of all the epithelial surfaces of the body. The eye dries out, you get xerophthalmia. The cornea becomes keratinized like skin. You get these foamy patches called Batot spots. And eventually, keratomalacia, the cornea, literally melts and perforates.
And it's the leading cause of preventable blindness in children globally.
It is. A simple, cheap nutritional deficit breaks the chemistry of sight and destroys the anatomy of the fortress.
We have covered a massive amount of ground here, from the water-fat sandwich to the cornea, to pool cleaner drops for parasites, to the blue haze of Viagra, and the snap of the retinal molecule. What's the synthesis? What's the big theme?
For me, the theme is respect the compartment. The eye is not just another organ. It is a sanctuary with its own rules, its own barriers, its own plumbing.
And its own vulnerabilities.
Exactly. Pharmacology in the eye is all about navigating barriers. We are constantly trying to sneak drugs in past the defenses or keep them from leaking out and causing collateral damage in the body. It requires a level of precision, both from the drug designer and from the patient, that you just don't see in many other fields.
Which comes back to clinical stewardship.
It does. It's understanding that a drop isn't just a drop. It's a systemic dose that bypasses the liver. It's a chemical that can permanently change the color of your eyes or the rhythm of your heart.
And adherence. We didn't dwell on it enough, but it's the ultimate weak link, isn't it? If the patient can't physically put the drop in, or they miss the eye half the time, or they don't occlude the punctum, the best science in the world fails.
The most expensive, high-tech, sight-saving drug in the world has zero effect if it lands on the cheek.
I want to leave our listeners with a final provocative thought. We spent a lot of time on the systemic trap, how these eye drops bypass the liver and can hit the heart directly. It really makes you wonder, what else?
What do you mean by that?
I mean, we tend to compartmentalize medicine. We think this is for my eye or this is for my skin. But the plumbing connects everything. If a drop in the eye can trigger an asthma attack or slow your heart, what are the subtle systemic consequences of the creams we use, the inhalers, the patches?
That's the ultimate lesson of Goodman and Gilman, isn't it? There is no such thing as a truly local drug. There is only the body and the intricate, often surprising, web of plumbing that connects it all. Every intervention is, in some way, systemic.
Something to think about the next time you use a nasal spray or a skin patch.
Indeed.
If you want to see the molecular diagrams of the visual cycle, which are surprisingly beautiful, or the chemical structures of those prostaglandins we discussed, go check out the Ocular Pharmacology chapter in Goodman and Gilman. It is dense, it is heavy, but as we found out today, it is absolutely worth the lift.
Yep.
Thanks for diving deep with us. We'll see you in the next one.